Good morning, everyone. Can you all hear me? Perfect. And online, are we good? Nice. I struggled with this last time. I didn't hold the mic close enough. So I'm going to try better this time. Thank you all for being with us here this morning during spring break here. Appreciate you being here in person, but also those who are joining us online. I'm going to start by reading our ancestral land statement that was put together by the NPHA Health Equity Committee. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial, and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. So again, thank you for joining us this morning for this second policy forum. I just want to start out with a few announcements very briefly, and we'll wrap those up again at the end. But for those of you who are MPJ members, and if you aren't, you should consider becoming one. There are the elections for the upcoming Governing Council Board that are open from March 20th to 18th. So check your inboxes and vote, please. There are also awards. You can nominate people for any of 7 awards that MPHA gives out at their award ceremony. That will be coming up in June. That is going to be open until April 16th. There's also the annual conference. The registration is now open. It's going to be in beautiful Duluth, my favorite place. And then National Public Health Week is coming up the first week of April, first full week of April, so April 7th through the 13th. I am going to pass it over now to our moderator, Shirley, who will introduce you to our panel and our session today. Thank you.
Thank you, Kristen. My name is Shirley Sherry, and I'm going to be your moderator today for our discussion. And I want to again thank everyone for taking the time to join us for this important conversation. Our voices, I guess, this morning. This year's Breakfast Forum series theme, Connecting the Dots, a Call to Action, is about pushing beyond traditional boundaries to address some of the most persistent and complex public health issues facing Minnesotans. We recognize that mental health is a critical piece of overall health and well-being, and addressing its challenges requires collaborative, innovative, and systemic approaches. Our discussion today will focus on the gaps, inequities, and opportunities in Minnesota's mental health system, and most importantly, what we can do about it. We are fortunate to have 3 outstanding panelists with us today, each bringing a unique perspective and expertise to this conversation. We have Todd Archbold, who is the CEO of Prairie Care, a leader in mental health care services. Megan Shasso, I knew I messed that one up, but director of the Upper Midwest Agriculture Safety and Health Center at the University of Minnesota, focusing on mental health in rural and farming communities. And Rachel Warren, director of the Brooklyn Bridge Alliance for Youth, working to support young people in overcoming barriers to mental health and wellness. I am not reading their bios. You should have access to their bios. But I want to again thank our panelists for being here. And so just to start out, so let's just dive right in. And each of you represent a different sector within the broader landscape of mental health. So as we go through this discussion, I want to encourage you to share your insights, real-world experiences, and practical solutions that can drive meaningful change. So to begin, let's just set the stage. First, if you could just introduce yourself, give us a little background on yourself, on your organization, the services that your organization provides, and then just any of, just if it's some of your bigger challenges that you might be facing right now. And so I'm going to start with Rachel, and then if the mic is on, and then when you're done, then you can just pass it on. So thank you.
Great, thank you. Good morning, everyone. My name is Rachel Warren. I am the coordinator of the Reimagine Black Youth Mental Health Initiative through the Brooklyn Bridge Alliance for Youth. We are working to really shift the narrative around Black youth mental health, strengthen the ecosystem of support for Black youth and their well-being, and change the conditions that are making Black youth unwell. So we don't want to simply give coping skills to Black young people while they continue to be harmed. Through policy change, we want to actually change the conditions that are harming them. This is a 3-year initiative. The impetus for it was the rise in suicide rates among Black young people over the past generation. The Congressional Black Caucus wrote a report sounding the alarm, which prompted funding from the Office of Minority Health. Minnesota Department of Health secured that funding in partnership with us, the Brooklyn Bridge Alliance for Youth, and we began the 3-year initiative. So over the last 2.5 years or so, we've engaged hundreds of Black young people around what supports their mental health, what disrupts their mental health, and what needs to be addressed in order to improve their mental health and well-being. We held a summit in year 1 that led us to 6 policy themes that needed to be addressed. We took those 6 themes back to young people through school assemblies and asked them what's the most urgent thing. And the thing that came out of it was keep Black youth safe at all times. This included safety online from bullying, safety in the community from gun violence, and safety in schools from racism. So we crafted a demonstration project, a demonstration of change around that first component of safety online from bullying, through a 3-part curriculum. Part 1 was around education, so we educated young people on the social media algorithm, their digital footprint, the traumatic impact of explicit content, and more. And then the second part of the curriculum was policy, and so their informed voice then influenced policies in their schools related to cell phone use. Legislation just passed that said all schools need a cell phone policy, and so we used the timing of that to say, okay, we want informed youth voice in that policy. And so they were able to influence their school cell phone policies. And then the last part of that curriculum was positive use. And so they crafted stop animation videos, skits, crossword puzzles, a number of creative channels to really show what they learned. And then really tie back to that bullying piece. How do we stop and disrupt bullying and expand that to our peers and our greater school community? So we have an advisory council of Black adults who are kind of the ecosystem that support this work. We have an affinity space for Black young people that is a capacity building tool that really helps drive our policy work. And then we have our youth interns who are at the core of this work. It's Black-centered, it's youth-led, and it's community-driven, ultimately to respond to and disrupt suicidality among Black young people.
Good morning, everybody. My name is Megan Chausa. I'm the Outreach Director of the Upper Midwest Agricultural Safety and Health Center. And I first want to thank the Minnesota Public Health Association for having this discussion, and also for centering the voices that are represented in the panel today, including the rural and agricultural perspective that I really bring today. And so a little bit about myself and the center that I work for. So I myself am a rural project myself. I graduated from a very small public rural school in southern Minnesota, and I think I had tea this morning. Several of us showed up. So I'm a product of a rural community. I grew up on a farm myself, and so a lot of my experiences are really centered in that experience I had in those rural communities. And I now work for the Upper Midwest Agricultural Safety and Health Center. We are a federally funded center based at the University of Minnesota School of Public Health. Ultimately, what we are funded to do is to improve the health outcomes of people that work in agriculture, so farmers, our families, and their communities as well. We do that first and foremost as a research institution. So we have 4 multi-year studies going on currently, ranging from farmer mental health. So we're studying farmer mental health, help seeking, it's helpful, but help seeking behavior. Do farmers seek help? What does that look like? How can we improve in that process? We also study, the bench science type things, if you will. So we're building an aerosol sampler that will be able to in real time measure what's in animal housing. So avian flu going on, some real tangible applications there. We also function as an outreach and community engagement institution, so that's where I do a lot of my work, both in translating the research that we do. So we're not just doing research for research, but we're doing research for our community. So taking that back out into our community, but also our outreach program looks like this, and talking with folks like you about what the work that we're doing is. We have a lot of really deeply entrenched community work. And one of our core programs is at Minnesota Farm Fest. If you haven't been, please come. There's sweet corn ice cream. But what we have tried to do in these kinds of spaces is, at Farm Fest in particular, we do live health and safety demonstrations, we do free health screenings, and we have, 30 plus exhibits. So we try to have this, what we call a suite of services that are really there to support the agricultural community, whether it's community mental health, substance use resources, all the way to really technical tractor rollover type things. And then finally, the UMass Center also functions as a funder. So we fund a pilot project program that really focuses on early career academics, ideas that need additional data in order to have a more robust research application, things I call funky ideas, so the exploration of the agricultural health and safety space. But we also have a community, what is much more like a community grants program, so that's called our Emerging Issues program, where we respond to the things that we didn't have in our 5-year plan. So things like our farmer mental health programs, our Aging on Farm programs have all been through that emerging issue or community grant program that we have. And so that's a little bit about myself and the UMass Center as well. I think the rural perspective for mental health is often one where a lot of the challenges that we see in our urban and suburban areas are simply exacerbated. So I'll maybe talk more about those as we get into it. But what we have done, especially in the farmer mental health space, has been in funding community projects. So my colleague next to me, Rachel, has talked about youth. So something we've seen in farm youth is that they're experiencing not only their own stress, but also the stress of their parents, grandparents, the people around them. And so they're having this multiple tiers of stress. And learning how to intervene in that process and support those youth has been something that we've been really focused on, for example, through our community trainings and projects. And I think I'm going to leave it there and let Todd introduce himself and get into more of the rural mental health as we go.
Well, thank you. My name is Todd Archbold, and I'm a social worker and the CEO of Prairie Care, and I'm really excited to be here this morning and engage with you all on this topic, and certainly being here with Megan and Rachel as well. And by the way, I'm sold on the sweet corn ice cream. You should sign me up for that. No, I'm really excited to be here and again be able to share about this topic. I started my career 20 years ago as a school counselor, and if you think about what school counselors did 20 years ago compared to today, it was quite different. I love the engagement with children, in particular the family systems, and really helping kids and families get the resources they need, the wraparound care to engage in education. Today, school counselors are doing psychotherapy. They're doing far more intense wraparound services. They're much more involved with interventions than they were at that time. But as I made the change from being a school counselor to working in healthcare, where I'm at now at Prairie Care, I moved to an environment where treatment was occurring, where I saw healing taking place. And it was a huge moment of gratification for me to see some of those similar children and families I'd worked with in the schools now getting better. They were with us. We were working with multidisciplinary teams with doctors and social workers and nurses and psychotherapists, and really watching leaps and bounds in these children's futures really kind of gain traction. And I've been at Prairie Care ever since. Prairie Care today is one of Minnesota's largest mental health care systems. We have our hospital in Brooklyn Park. So Rachel and I have that connection in that community where we have 100 beds for children, adolescents, and young adults. Centered around our hospital, we also have several outpatient programs throughout the metro area and also in Rochester and Mankato, and we provide telehealth services. As we've been expanding over the last 18 plus years now, we've been really excited not only to create more access to these critical services, but also really developing what we call our continuum. The fact that we can offer free assessments up front for anybody who's seeking services, which is often intimidating. People don't really know what they're looking for at the time. In fact, a timely comparison I create is I filled out my NCAA bracket the other day. Many of you probably did that. And I don't know the difference between Texas and Texas Tech, and I still don't know where Gonzaga is. But when people are trying to access mental health services, understanding the difference between a psychiatrist and psychologist is intimidating. Understanding the difference between a community-based clinic and a healthcare office is intimidating, much less how is it going to be paid for, et cetera. So we've really worked hard to kind of get rid of those barriers, increase access to care, but again, create a continuum where you can start with a free assessment where we can help connect you with the right community provider, whether it's Prairie Care, one of our partners out there, and all the way to our inpatient hospital level of care and even residential programming that you can receive within the same system. And I want to point out too that Prairie Care is one thread in the fabric of Minnesota's mental health care system. There is not one organization that can do it all. It's a challenging service to provide. It's a tough business model, if you will, and we truly need to continue the communities to come together to provide these services together. The last thing I'll say is I just want to share one of the mantras that we have here at Prairie Care we talk about a lot is the fact that mental illness is real, it's common, and it's treatable. And starting with it's real, it's not a character flaw. It's not in your imagination. It's not psychosomatic. It is truly a condition that we can see, we can hear about, and we can respond to. And it's important that people understand that mental illness is real, and it's common. Nearly 1 in 4 out of 5, 4 or 5 people in their lifetime will experience diagnosable symptoms of a mental illness. And I like to expand on that by saying, put your hand down if you felt depressed before, if you felt anxious before. We've all felt these feelings, maybe not to the extent that it's impeding with our ability to function on a day-to-day basis, but we know what depression and anxiety is like. 1 in 4 or 5 people will experience those symptoms to the extent that it is inhibiting their day-to-day functioning, and they will need treatment. Which brings me to the last piece, mental illness is treatable. There are so many wonderful providers out there engaging in psychotherapy, more intensive treatments. There are some really innovative solutions with something called TMS, transcranial magnetic stimulation, that can truly help nearly everybody experiencing these symptoms experience improvement in a matter of months if they engage in treatment. So excited to share more about this with my fellow panelists and engage in conversation with you all.
Thank you very much. Very informative. Keep your hand down if you have ever experienced anxiety. I'm going to keep my hand down because I've been experiencing it ever since, majorly ever since COVID. And I think many of us in public health have done that as well. So thank you. Let's just think about our biggest challenges. And what is the most significant gaps in our current efforts to provide mental health resources to the communities that you serve? And who would like to start? We don't always have to go in order.
So in terms of gaps and challenges, I'll share for us, because we don't provide clinical mental health services similar to some of my other panelists. We are a community-driven, youth-led policy initiative. And so in terms of gaps, I'll share what young people identified as those 6 policy themes or 6 policy areas that need to be addressed. The first, like I said, was keep Black youth safe at all times. And that included safety on social media from bullying, safety in the community from gun violence, and safety in schools from racism. The next is give Black people the space to create their own space. Prioritize the needs of Black young people as identified by Black young people. More Black teachers in schools. More education on Black history more often, including learning beyond academics, and addressing generational trauma. Those were the 6 themes that young people named and uplifted as if you respond to these things, our mental health and well-being will improve. And so their response to that question wasn't, you know, we need more therapy. It was, no, we need more Black teachers in schools. We need to address generational trauma. Now, therapists can help do these things. And so I think there's through lines and, through lines in ways that there's overlap for other services. But the things that they named were really eye-opening in terms of if you address these things, our mental health and well-being will improve. So in terms of gaps, those are the areas that I think need more attention. I think too, it's been really cool to focus specifically on Black young people in response to suicide rates for Black young people. Oftentimes we group, BIPOC people, or we group, Native and Black young people. And so I think the rise in suicide rates among Black young people over the last generation were among Black young people. And so to be able to respond to that specifically and intentionally has been really inspiring and really cool across our community. In Brooklyn Park and Brooklyn Center, there is a lot of diversity among Blackness. There's no one way to be Black. There's Black immigrants, there's African, there's Black American, and so seeing how young people, Black young people, come together under the umbrella of Blackness, but with similar issues that they're facing, has been really interesting and very complicated, but very inspiring in ways. And so in terms of gaps, I'd say those 6 policy areas. And then also just the dynamic between Blackness and understanding that in the context of mental health and well-being. There's a difference between mental health and mental illness. And so I think also discerning that and recognizing that we're talking in our initiative about health and well-being, about the inherent goodness of Black people, about Black joy, about the things that are well and working and good in our communities. Has been also something that we're really intentional about, that we're not deficit-based, that we aren't, focusing on Black pain, but really focusing on the loving of Black joy. And so I think just recognizing that distinction is really important as well.
I just have to say thank you, Rachel, and hearing someone talk about addressing the systemic and societal challenges that are contributing to mental health, I think is exciting. And something that we do talk about in the rural space a lot is that there are so many rural assets. I think thinking about those assets and communities is perhaps more salient than ever. I don't know. So challenges and gaps in the rural space in particular. I mean, when I think of challenges, I just think of the general state of rural health. And like I said earlier, a lot of what is happening in rural is really an exacerbation of what we're already seeing in suburban and urban communities, right? So it's hard to find a specialist. It's hard to understand the technicalities between those all. And that's much more difficult in a rural space. And maybe you have a challenge with transportation or a referral system. And so I think that's really the umbrella description I use for people is we are familiar with what's going on in a rural community, and it's really being amplified. And so seeing things like, well, first, when it comes to rural mental health itself, when it comes to rural mental health itself, we see pretty comparable outcomes between rural people and urban people. So fairly similar when it comes to mental health outcomes. However, we do see that things like poverty, things like substance use disorder are disproportionately affecting our rural folks. And so having those kinds of things to really amplify rural mental health problems is significant. I've also mentioned, distance to care really does come into play for folks, especially when you come down to things like that specialty care. We've been doing a lot in the, like I said earlier, the aging space, so not a complete overlap with the mental health problems, but definitely they share a lot of similar challenges. So we've been working on improving referrals, especially in neurologic conditions, because what we see with the group we're working with out in Big Stone County in Southwest Minnesota is that physicians don't even have the capacity to get referrals to more specialized care. And so how can we intervene and help improve that process? Something we hear a lot is, that maybe telehealth can be the silver bullet, and I think it's a part of the solution. And we do still also see a lot of rural communities that don't have broadband and maybe don't even have cell phone service. I am from the driftless area of southeast Minnesota, and there are many areas that don't have cell phone service. And broadband simply is not an option also yet in many of these communities. And so I think anchoring that, these are the lived realities for a lot of rural people is important. Something that I think about a lot when it comes to the gaps in rural mental health care in particular, we oftentimes center this around the framework of the 4 A's, which is pretty common. The A's sometimes vary a little bit, but affordability, availability, accessibility, and acceptability. And so those really, I think, help to structure what some of those challenges and gaps are. So affordability, something that as panelists were talking about before we even got started is Medicare and Medicaid. And also with rural people, we see more people who are self-employed, uninsured, underinsured, and so affordability can really become an issue very quickly. Availability, like we've said, there are very few rural counties that have one psychiatrist or one therapist. And that's not really even accounting for the fact that we need culturally, I struggle with culturally competent, cultural humility in our care. And so, the availability is a significant challenge. And in rural, we have this layer of privacy. And I was listening to a podcast on my way in about substance use in rural communities, and that people will oftentimes not avoid getting care because they have an aunt or a cousin working at the clinic. And the same is true for so much of rural mental health care. I hear the example a lot of people will say, I don't want my car to be recognized outside of the therapist's office. And that is actually such a real thing that I will still, to this day, I'm many years removed from high school, that I will see a car and think, oh, is that my high school car? Of course it's not. We're how many cars removed from high school, but you truly do have that level of familiarity with your community, which is also an asset. We'll get back to that. But when it comes to a space where there's maybe really limited care already, that lack of anonymity in this space where there is still unfortunately a lot of stigma, it really is a challenge as well. So affordability, acceptability, availability, and also that acceptability piece. So are people accepting that for mental health is normal? I think we've made a lot of progress in rural and farming communities, but I think there's a lot more progress to be made in that space of normalizing for mental health. And also Todd, I wrote your phrase down that mental illness is real, common, and treatable. Really bringing that message to our communities. So that's kind of an overview of some of the key challenges that we work with and also some of those gaps. But I also think some of those gaps are really important in framing some of those potential solutions, which I'll pause at for now and let Todd talk about how prairie care is interacting with these challenges and gaps.
Thanks, Megan. And I'll maybe be somewhat brief to talk more about, I think, a gap that I think we've done a nice job bridging. But first, I do want to comment on telehealth. I'm glad Megan had brought that up, and I want to kind of reinforce what she had said. You know, telehealth has been a highly effective tool, hasn't been a solution. In the onset, in the thick of the pandemic, we saw in mental health care, telehealth use go from about 5% of overall visits to nearly 70%. It didn't increase the number of individuals we could care for. In fact, it was kind of a net wash. Rather than coming to the office, we saw you on video. So it hasn't increased capability necessarily. And also, I saw a very interesting report, I think it was published by the Department of Health last fall, where they were promoting the efficacy of telehealth and wanting to ensure that we can continue with these practices, that continues to be reimbursed. And interestingly, there was this heat map of where people were coming from who were using telehealth. And sure enough, it was the metro. And there's always been this thought that we'll reach, quote unquote, greater Minnesota via telehealth. And yes, that can be helpful. As Megan pointed out, in tech, they talk about this last mile problem. It's easy to run a fiber line of internet up to greater Minnesota, but that last mile of getting it to people's homes is a much bigger challenge. So it's a great tool, but it hasn't been a solution. And I certainly hope that we can continue to maintain those services. But again, there still is much left more to be desired, if you will. But the gap that I think we should be proud that I think we've done a nice job at, as evidenced by these panelists, is awareness. The fact that the three of us have this microphone, that we're talking about this, that all of you have likely had conversations about mental health in your homes, in the workplace, is significant. And I have far more hope with the individuals doing this, the individuals talking about this, than I do our systems. Our systems remain fragmented, they remain limited in many ways. Sue Ackerholden, the executive director of DOMI, we spoke at a prior panel, has a great quote: "Our mental health system is not broken because we've never built it." So although our systems leave a lot to be desired, it's the people. It's all of you today engaging in these conversations that have done an extraordinary job raising the awareness, helping to normalize the conversation so we can talk about our mental health, and when it comes to that point, we can talk about the illness as well.
Great, thank you very much. What I'm going to do is kind of combine the next two concepts. You did a really good job on also identifying, you know, the inequities in accessing mental health care in your areas as well. And I want to move into thinking about collaboration, because collaboration is key, and also service coordination, which is critical, because we have a couple of different sectors. And so when we think about collaboration, with whom does your organization partner to reach those in need? And are these collaborations, do you think that they're effective? What other kinds of additional partnerships could be developed? And then as we think about the service coordination, are there overlapping services between organizations? And with that overlap, how would they be how are they managed? So you can start.
All right, since I have the microphone. One of the coolest things I've done in my entire career happened about 2.5 years ago, right here in Minnesota. We created a grassroots movement, created something called the Mental Health Collaboration Hub. And this was born out of the crisis that was exacerbated by the pandemic of what we know is kids and adults boarding in hospitals. We saw this literally with COVID, the horrors of needing overflow facilities and people not getting care and being in hallways, etc. We now saw this in mental health care, those in psychiatric crisis. And by the way, this has been happening for many years, the last couple of decades at least, but now it's started to get attention, and specifically with children. All of the kids who couldn't be cared for in their home environment were having a lot of times externalizing conditions where they were brought to hospitals for care, and they were stuck boarding for not days, sometimes weeks at a time. In response, our healthcare community, the hospitals who were oftentimes boarding these kids, counties and mental health providers came together on initial phone calls, basically just to say, what's going on? What can we do about this? And slowly we started talking about individual cases. Well, what about this child who'd been at such and such hospital for several days, several weeks? What do we do? And we started to make connections. And quickly we had the idea, hey, we could probably turn this into an electronic tool, a de-identified portal that we now call the Mental Health Collaboration Hub that allows any hospital, any county, any organization that's truly kind of quote unquote boarding a child, in other words, somebody who we deem will benefit from mental health care, but we can't get them to that service for one reason or another, they now upload de-identified information into the hub. The hub matches them to hundreds of mental health providers across the state, ranging from hospitals to residential programs to foster care settings. It alerts those individuals, and then we facilitate the transfer to those safe care environments. We've now cared for more than, I think, 450 kids who've been uploaded into the hub. We have hundreds of users, I think about 300 organizations participating. It's been truly one of the most transformative things I think we've been a part of here in Minnesota, that I've been a part of. And what's really cool about it is people don't really know it exists. In other words, our communities don't know it's a tool that our providers are using to help facilitate communication and ultimately, like it says in the name, collaboration. Beyond helping those kids get to the care settings they need, it brought together a community of hundreds of providers who are now having these conversations that weren't happening before. Again, it's been truly transformative to see that we've helped hundreds of kids in addition to the collaboration and the conversations that are happening. Has been really inspiring for me.
We almost exclusively work with external partners, and so, you know, the UMash team, I am one of 2 full-time people, so we are small but mighty, and so I talked a little bit about our outreach program and that we act as a funder, so really a lot of our work and service providing does happen with our partners and out in the community. And one area that I've been particularly excited about has been an initiative we developed for supporting women in agriculture in particular. So something that we had seen really anecdotally was that women in agriculture, like women broadly, were wearing a lot of hats. They were, first of all, they were farmers themselves, and they were raising families, working off-farm jobs to get and keep insurance for their family, working on committees, involved in their community. And there really hadn't been any study on women in particular. And so we first surveyed them. We said, are you stressed? And they overwhelmingly were. And from there, we really wanted to build some community programming that would support this population in particular. A lot of this worked for us. We had a couple of conversations before the panel started about there have been many farm mental health crises over the years, but our current ongoing really got its legs in the 2016-17 era. We went to host a panel out at Minnesota Farm Fest again, and it was supposed to be about like diseases in animals, and we had a farmer stand up and say, I've had several neighbors that I've lost to suicide. What are you doing about that? And you know, we really focused on occupational health and safety, and we were like, well, you know, that's not occupational health and safety, but it really is. Mental health is a part of worker health, and mental health is a part of individual well-being. And so we put a lot of resources into this space. And so when it came to these women in agriculture in particular, we developed a kind of 2-pronged program. So we're both just following, you know, this 2018, so by the time we got around to it, we were right around COVID, and so we developed some online programming because, again, we were seeing with COVID that things, the stress in most communities was only being exacerbated, especially animal agricultural communities. We were seeing a lot of farmers have to depopulate their animals, and it's incredibly stressful, emotional, and traumatic process to go through. And so we created these 2-pronged program. Its name is Cultivating Resiliency for Women in Agriculture. And this one component was really designed to empower, build skills, build confidence and competence. So we were doing these webinars on everything from farm financial planning, navigating conflict, working with your attorney, you know, things that were tangibly building skills for folks to be working effectively in their family, in their farm business, in their community, whatever it may be. But we also had this corner of the programming that were called coffee chats. What was different about these is there was usually a loose topic. So kind of like these forums, there was a topic, so people would say, oh, you know, it's almost fair season and families are doing a lot around fairs. Like, let's touch base on that. But really what they were is they were an online but anonymous. People did not have to identify themselves to participate. They could and many did. But they really turned into support groups where people could anonymously share what they were going through or build community. And we had a number of folks that, and this is an ongoing program, that when we went to evaluate said that this kind of programming saved their life. And I think that was the most impactful thing I've heard in my career to date. You know, public health work is some of the hardest to evaluate because you're trying to measure some things that are not happening. And so to hear, you know, those kinds of impacts, I think is exactly what it is the best we could have hoped for as a center. And so, you know, when you ask about, you know, what was effective, I think we really saw that that was effective. But something that is particularly on my mind recently, and you know, still really does still exist as a gap, are, you know, there are so many subpopulations within our rural communities, and thinking about our migrant and immigrant communities right now in particular, and how we support their mental health. I think we have been really making an effort in this space for a while, and we know that folks are more scared than ever. They're withdrawing from their communities and their touch points and organizations, and so I think when we think about what more needs to be developed and who needs to be focused on, for us, that's really a population that we're really thinking about and trying to strategize of how do you safely do that work for them as well. And so I'll leave it there and let Rachel weigh in on collaboration, search coordination.
Thank you. So first and foremost, in terms of collaboration, our partnership is with young people. At Brooklyn Bridge Alliance for Youth, young people are our North Star. They are our colleagues, they are our partners. And so youth are the #1 partners. Like I said, we have our core youth interns who are a group of high school young people that we pay to be a decision-making body for this work. We also have our Black Youth Space, which is an affinity space for Black young people ages 12 to 22 to come together and really build community, tap into their history and culture, and experience mental health and well-being in real time. That we use as a capacity building tool to move this work forward. So between our interns and our Black Youth Space, we really try to be true to this initiative being youth-led and leaning on young people to really drive and decide what we do in this work. In addition to that, Brooklyn Bridge Alliance for Youth is an alliance of 9 program partners. We partner with the 4 school districts that are connected to the Brooklands, which is Robbinsdale area schools, Anoka Hennepin schools, Brooklyn Center Community Schools, and Osseo area schools. So we have the 4 school districts, we have the 2 cities, Brooklyn Park and Brooklyn Center, and then we have the county, and we have the 2 colleges, North Hennepin Community College and Hennepin Tech Community College. And so those 9 program partners make up the alliance, and all of them sit on our advisory council for the Reimagine Black Youth Mental Health Initiative. So our advisory council also includes community partners, like nonprofit organizations, community healers, religious organizations, and folks who really have stake in making young people well. So between young people, the alliance partners, and our community partners, that is how we kind of carry this work forward in terms of collaboration.
Thank you so much. Such a rich discussion. So now moving on to the next part of our forum, we'd like to hear from you. Our policy forums are designed not only to provide valuable insights from our panelists, but also to foster meaningful discussion and networking. So each table should have index cards and I think pens available. So please use them to jot down any questions that you have for our panelists. And then members from our policy forum committee will go around and pick up your cards shortly. We'll do this till about 9:05. So also get up, stretch. We've got coffee, we've got treats, use the facilities, and just looking forward to the next part of the discussion. So thank you.
So how are you doing? Good. How are you? Not too bad. So I'm still out of the presentation, but I think you got a good chunk. Okay. Okay.
They're good speakers.
Yeah.
For sure.
but hopefully we'll get through the majority of them. I'm going to start with the coffee chats, and so that was Megan. Did you map where participants were from? And were people interested, were they from all over Minnesota? And like just a sense of how many? And then with your interventions, how have they been evaluated? Maybe that's for both you and Rachel.
Something I don't think I mentioned in my introduction is that we are a regional center, and so UMass covers a 5-state region of Minnesota, North Dakota, South Dakota, and Iowa. And so when it comes to the coffee chats, we really did bring in folks, actually globally, heavily from the upper Midwest, which makes a lot of sense. But we have, in that program, we have an imperfect system. So for the coffee chats, like I said, folks can be anonymous, and so we don't have a perfect number, but we estimate close to 3,000 participants over the years. And so evaluation on our coffee chats has been, highly qualitative. So like I said, the way we heard about individuals saying, this saved my life was because they shared that out loud. But a lot of the way we've evaluated, that coffee chat program in particular has been, we survey participants on a voluntary basis. But a lot of our other programs, it's really, I'll be honest, it's really hard to measure, but we're able to see how many people, where. We are able to capture things that people say, like, oh, this has changed in how I approach communication with my family. We get a lot of insight like that on a regular basis, and so we're able to track things like that. And so that's a little bit of insight of how that evaluation looks. But we have also had programming in, we're not the leader in agricultural youth stress and mental health, but we did have, I mentioned one project where we were looking at, I talked about how we saw that kids were experiencing their own stress and then their parents' stress. And so a strategy we have a lot in health and safety is just sneaking things in. And so we've done that with mental health a lot. We have an existing training, and then we toss in a behavioral health segment. And so we have been able to measure in a training over the years, just are these youth that are going through this training experiencing stress? What are their coping mechanisms? And then we also do post-testing. So we have been able to see things like improvement in understanding of coping skills, improvement in understanding of available resources, skills for confrontation. And so that's really kind of what things have looked like for us. I hope I answered that question. And maybe I'll let Rachel weigh in on intervention evaluation.
Great, thank you. So in terms of evaluation, we've done from surveys to really creative, documentary videos for evaluating our interventions. With the surveys, for example, our curriculum, we found that 86% of young people felt that the curriculum was useful for their mental health as a Black young person, and 77% of them actually changed their social media behavior based on what they learned in the class. And so we've done surveys for evaluation, but we've also done round table talks where we have hour-long documentary-like videos where we get young people in a room to have raw conversations around mental health and well-being, as well as the aspects of the program from Reimagine. So we're very creative in terms of how we evaluate. We have a full-time evaluator through MDH who does our evaluation and helps with making sure that we capture not only the process, but the results. We're also doing ripple effects mapping where we can see how what we're doing has impacted other spaces or other people through what we're doing. So that's another key piece of our evaluation. So there's a variety of how we make sure to evaluate our interventions.
Thank you. So how are programs in the rural areas dealing with hospital closures? And can you just talk a little bit about about mental health and hospital availability, et cetera.
Yeah,
I guess that's right.
Yeah, from our experience at Prairie Care, our mental health hospital is a destination. And we could have built it in Brooklyn Park, we could have built it in Grand Rapids or Rochester, and we are near capacity almost every single day. So unfortunately, those closures have only made it that much more difficult for individuals who already had a lack of access to care. And it's just made it that much tougher to get services with us. Again, telehealth we thought would be more helpful than it has been. It's been an additive, it's a tool, but it certainly hasn't been a solution. So I'm going to hand it to Megan. She might have more of a perspective on this.
Something that I'm thinking about a lot lately are these like innovative models of care and insurance. And so I'm going to be drawing more on my personal experience than my UMass experience in this. I think I mentioned I'm from this rural area in southeast Minnesota, and while it's a hub of healthcare, you have Gunderson Lutheran System, Winona Health, you have Mayo. It's also a real desert in a sense, in that health insurance is extremely tricky in the area. There's a lot of farming, there's a lot of self-employed. So even though we have the Mayo Clinic, a lot of folks are not able to access that. And so something that I've seen a lot in my own community that I grew up in are things like insurance cooperatives, or even a real increase in clinics that are just not doing insurance. They are cash clinics, and that has made a real difference, I think, for a lot of rural people. There's a person in my life, I won't say who, but they did not have health insurance. They worked in farming, so very, very worrying to think about. And they did not have health insurance for over 5 years. And that made this person, but this person became really good about preventative health care during that time, which is kind of ironic. But it was really these co-op type settings and this health clinic that was, a cash only place that was able to provide care. And so I think, I don't know that that's entirely a solution, but I've been seeing more of that, and I am intrigued by some of these solutions and hubs. But I will say, I think the hospital closures are, absolutely detrimental to these communities and are exacerbating a lot of challenges, especially labor and delivery seem to be some of the first to go. And there are a lot of expecting people that are 2 hours away from OB care, and I think that's a really scary place to be in. I had a colleague it's an organization called the Agricultural Utilization Research Institute, AURI. They do really cool stuff. But someone there said once, one of their indicators for healthy rural communities is seeing playgrounds, like new playgrounds when they're driving around. And so, being able to have youth in these rural communities is more important than ever, and also seeing is just devastating in labor and delivery care. I don't have a solution on that end, but I think it's something that is very much on my mind.
Thank you. Let's move on here. This is just in general. We have our, thinking about our state legislature right now in regards to mental health. So, just thinking about mental health resources, what things do you envision for our state legislature to address right now, and maybe what are some possibilities for the next session to talk about? So just thinking about that piece, just spend a minute.
Yeah, so we, like I said, the policy kind of priority or theme that we're focused on is keep Black youth safe at all times. And there's those 3 components of safety. So next Friday, actually, we have a Black Youth Mental Health Day at the Capitol, where we will bring young people, about 100 young people to the Capitol, Black youth, to really uplift that priority and speak to elected officials around their personal experiences related to those aspects of safety, and their experiences related to Black youth mental health in general. So I think that day is going to be really a unique day to uplift specific priorities, but in addition to that keep Black youth safe at all times priority, we have those 5 other priorities, including addressing generational trauma, more Black teachers in schools, you know, and the like. And so in terms of what we'll be kind of advocating for, it's those policy priority themes that young people have identified over the last 2.5 years.
For our space, well, I will say we are federally funded and we do legislative education work only. But here in Minnesota, something unique. Minnesota's been kind of a shining star for rural and agricultural mental health across the country. So here in the state, we have 2 rural and agricultural therapists that are completely free to farmers and farm families. Their names are Monica Kramer McConkey and Ted Matthews. They are both funded by the state of Minnesota, and so there is work currently to sustain and actually expand that if possible, because like I said, there are 2 for the whole state. They do telehealth or phone calls, they travel, they do a lot of sitting at farm kitchen tables, talking with families, but they are so busy. And they also have that cultural humility. And so I think looking at something like that is really important. Here in Minnesota, we also, you know, less on the mental health space, but on the health and safety angle that I really focus on. We have a cost share program where people in agriculture can make improvements to their operation, and the state will share costs with them. So that's another thing that we are hopeful to see. But I think from what's currently happening, you know, that's something that we're excited to see. I will say the community health worker is something that I think is so important, underfunded, and we really do have been working for years on how do we really support community health workers, because something about rural is things are far apart, home health care is so important, and so thinking about it in that policy space of like how do we really continue to support that like community health worker role has been something that we've been focusing effort on.
This is such a great question, of course, so timely, and I've been really grateful for so many of our policymakers and advocates in the community who really have, I think, put Minnesota on the map as a place of innovation and really prioritizes health, education, well-being. And I think our priorities need to focus more on sustainability. Although we've had a lot of creative projects out there, really neat things happening, they have not been sustainable. Just over a year ago, DHS published a rate study focused on Medicaid, and it confirmed what we all knew. There are many services that aren't covered, many of them are carve-outs, and there are a lot of services, most services, almost all of them, where Medicaid is paying nearly 70% of the actual cost of providing care. Medicaid is the single biggest funder of mental health and behavioral health services in our state. And it's been underfunded, and of course it's in further jeopardy. As we've been beating that drum as providers, we've gotten a lot of very positive attention and nodding heads and no action. I had a legislator once ask me, well, Todd, what would you do if we gave you $1 million? I said, I would build a beautiful, shiny clinic with telehealth capabilities and a beautiful, safe, healing environment, and then watch it go out of business in a year. As I'm looking at all the cars in the parking lot behind you all, imagine if none of them had gas tanks. We have resources, we have capabilities, but they're not sustainable. And what it does, it creates the need for subsidization, shifting of expenses and reimbursement. It puts more pressure on commercial plans. We see rates, premiums increase there. Somebody from a county once told me very wisely, our communities will pay for it one way or the other. Whether it's today, whether it's tomorrow, or whether it's with terrible outcomes. But we have to invest, we have to create sustainability. And I know there are bills out there, we're looking at rate reform, all sorts of really neat things I think need to have happen. And we'll continue to push for those things as we can.
Thank you very much. And moving to, there were a couple of questions in regards to federal. So, Medicaid, it's both state and federal combination of funding. But in thinking about what's coming about with our federal government and our political environment, how has that had an effect on your organization? And I'll just give a little example of a question. You know, has the DEI elimination, has that affected your organization and your funding, et cetera?
I'll do a quick response. Interestingly, Prairie Care is a private health system here in Minnesota. We have, other than Medicaid, Medicare, we don't have that federal funding. We do some grant work locally with the Minnesota Department of Health, but we've been able to continue to chart our own course and maintain all of our DEI initiatives. Although there's been a lot of terror, of course, happening at the national level, I think we've so far been in a place where we're, I think, like many, anxiously waiting and watching.
Yes, we are fully federally funded, and so we have indeed been affected, and unfortunately, I'm also not allowed to comment on it significantly for the university. So I will just say that we have been affected, and yeah, we're worried. I think even if things were to turn around and change and be better today, I think a lot of what has happened will have consequences for a really long time. Something I can comment on is, you know, we've seen a lot of review panels canceled. So whether that be for publications, for new centers, or grants. And so anecdotally, it seems like there are parts of the federal funding system that are functioning, and it's really unclear the rhyme or reason in some cases, but yes, we're still funded for now, and I will leave it at that, but if folks want to talk to me individually, I'm able to say more.
For us, we have not been affected yet. I think, like Todd was saying, we're anxiously waiting to kind of see what happens. I think one way that we've seen the impact is just our young people feeling more out of control when they see adults acting a certain way. It impacts how they can navigate the world. I think we've seen a lot of impact from ICE in our community with African immigrants, and how that is impacting young people and families is very traumatic. And so I think we see kind of the impact in the relational sense, but in terms of funding, our grant was a 3-year grant and will be ending this fall unless we can fundraise for more. We're applying for new grants as we speak, and hoping to kind of sustain the work that we're doing. But in terms of immediate impacts, gratefully, we haven't had any yet.
Thank you. We're so fortunate to be in Minnesota, where our state in general is supportive of keeping on with our DEI initiatives. Thank you. So one last question here, and I'm going to kind of combine a couple of things, is what can we as the general public do to help improve the mental health of each other? And then also thinking about, you had said that Sue had talked about that our mental health is not broken because it hasn't been built. So just thinking about, okay, so how can we help one another, but what are the steps to build the mental health system? We have 5 minutes.
I'll keep it brief. I think 3 things. The first is listening to what young people say, and really prioritizing their voice and change. I think the second thing is providing clarity to what public health is and does, so that people can articulate what the work is that's being done, and what the support looks like. And then I think 3, investing in initiatives like Reimagine, where there's innovative approaches that are community driven and youth led, so that we can have kind of those solutions that may not exist already in our communities and for our families and our young people.
Something really tangible that I have heard over the years and really like is that, and this phrase is a very broad overgeneralization, but that not asking for help is anti-community. And so this idea of seeking help or providing it is like, that's what helps us build community, and it is such a protective factor of our mental health. And so one of my favorite podcasts I listened to, they ended by saying, take care of yourself, and if you can, somebody else. And that language has always resonated with me. But when it comes to the rural mental health system, something that I think about a lot is, and I've alluded to, is how the rural economies have changed. And I think it's hard to talk about rural mental health without talking about the fact that mental health is poor in part because of rural economic desertification. And I can't go into those reasons in just a few minutes, but on the agricultural side, we saw agriculture become extremely mechanized, and that isn't inherently bad, but it changed the nature of these communities. And so I think economic support of rural communities really has to be a priority, and that is also rural mental health support. And so I think we're in a really difficult time, but thinking about the systems that are actually causing the harm. When I first got into rural mental health, people were like, we need more therapists. And I was like, yeah, but why are people so unwell? And we haven't gotten there yet. And so I think moving in that direction and really systems-based work is important.
Those are such great comments, and I think as we've kind of demonstrated, we need everyone. As I mentioned before, Prairie Care is one thread in the fabric of our mental health care system. You've heard from 3 very different panelists representing very different organizations, and we are 3 of, 5,000 in the state that comprise this fabric. We need everybody, and as I mentioned before, I have far more hope and am more inspired by the individuals, all of you, everyone doing this work, than I am in any particular system. Systems have limitations, systems can be obtuse, they can only do so much. It's the people that truly power our system, and just keeping these conversations going, all of you being here, participating, submitting questions, that's what gives me hope. It's the people.
Thank you so much. Again, this was such a rich discussion. So I'm gonna, if you have like a minute each of just a final, whatever you want to say, just final parting for all of us. And maybe it's just a little bit about, well, this is a public health community. What can public health do?
I might have just said mine. But yeah, just thanks for the engagement. We just need to keep it going. We're always going to have problems. We tend to mythologize the old days of, 5 years ago we didn't have this, and 10 years ago we were better at that. We had problems then too. And it takes the tenacity, it takes the courage for us all to continue together. We're going to have more different problems in the future. It's going to be the people, it's going to be the creativity, the tenacity that we bring to the table together that can solve for these things.
I also think that, innovation is just so important. I talked about how there are these new models of health insurance with cooperatives and these new models of care. And I think some of the solutions are not in front of us yet. And so I think the people, like Charlie said, are just such an asset and are honestly what gives me hope as well. And to be able to have these kinds of discussions and this level of awareness, I think really does move the needle.
I think both panelists have hit the nail on the head in terms of people being the asset. I think, just it's easy to get involved in the system of things and lose the people of things. And so I think as close to a community as you can stay, as connected to people as you can say, especially those with lived experience, whether it be young people, whether it be Black young people, whether it be folks in rural areas, whether it be in treatment facilities. As a public health system, as close as you can stay to those experiencing the mental health crises, I think is very valuable.
Thank you so much. So what we've heard is that we've got our first steps, our building blocks for the local public health communities to continue the conversation, and just in general to think about what are the steps and how to stay involved really close to the community. So as we conclude today's discussion, I really want to extend my sincere appreciation for our panelists. Let's give them a round of applause for sharing their expertise and perspectives. Mental health is not just a healthcare concern, it's a public health priority. It's social justice, it's a social justice issue, and it is a community responsibility. And to create lasting change, we must continue to work together across sectors, across disciplines, across communities, and to develop policies and systems to ensure equitable access to mental health resources for all Minnesotans. So before we wrap up, I have a couple of announcements. Kristen did mention them as we open, but the Minnesota Public Health Association's 2025 annual conference is going to take place May 15th through the 16th in Duluth, and with virtual attendance options available. And just to note that early bird registration is open until April 4th. So, you know, if you want to have a discount, please register in advance. If you're not an MPHA member, we encourage you to join. We provide valuable opportunities to connect, to advocate, and to give voice to public health issues in Minnesota. And you can learn more by going to our website, www.mpha.net. For current MPHA members, election ballots, the voting is open. It should have come into your email box last night or yesterday afternoon. So please vote. And our next forum is May 2nd, and the topic is housing. And this is another important issue to learn more about. So again, thank you for being part of this important conversation, and enjoy the rest of your day. Thank you.
That's the thing about being retired. Yes, you can. You'll find lots of things to do. I bet. Yes. But I have to keep a few fingers or toes in public health.